Good morning. Good morning to all my fellow oral engineers in the room and doctors, ladies, gentlemen, thanks for coming. We're going to be talking today about an entire team approach, and we're here for one reason. We're here to change things. This is really important. The golden triangle, it takes all three corners of this triangle operating on a very high level of communication, being on the same page. This is what it's going to take to do this technology at a very high level. If all three corners are communicating, talking to each other, it's amazing. The winner is going to be the patient. The implant surgeon working in harmony with the restorative team, and there's some key terms in this statement, to create a prosthetically driven and reverse engineered plan. Okay, those are key terms, prosthetically driven. This is where it's at. Communication is the key. Okay, but let's talk about cross-training for a second. We do work together. I think this is important. I haven't heard anybody talk about this. That's why I want to talk about it. If you're lucky enough to be in a situation where you work with implant surgeons, or prosthodontists, or between the two, between the restorative team and the surgical team, if you're lucky enough to be in a situation like that, take advantage of it. It goes both ways. Planning on Nobel Clinician, which you saw earlier, of us getting together, that's not easy to do, to get three professionals all together at the same time to clear their schedules and sit down. Now, even with Clinician on Nobel Connect, I think that the first case or two, it's still good to do that. It's still good to make an effort to get together with mounted study models and millimeter rules and CT scans and really sit down and have a good old-fashioned powwow and talk about vertical spaces and AP spread to make sure we all understand. But once a surgeon and once a restorative doctor's had a few of those planning sessions in person, then we can start to simplify the process and make it a little more efficient and a little more easy by using something like Clinician that's shared on Nobel Connect. It's a snapshot into the future. Almost think of it as a crystal ball.
And so what we kind of want to do is just walk people through the entire process of how we tackle these cases, how we approach them, how do we treatment plan the case, and then ultimately how do we achieve a successful final restoration. And essentially there are two choices. To keep it simple, there's the implant-assisted restoration. The other option for patients, the next step up basically, is the implant-supported restoration. Now we're removing the functional load from the soft tissue and transferring it to the implants entirely, and this is what we're going to focus on primarily today. Now, one of the biggest downsides to implant-assisted cases is that there's a much larger bulk of the denture. It's a better version of a denture, but it is still a denture, and that's one of the biggest downsides that we discuss with our patients in this type of case. So, kind of the next step up is the implant-supported prosthesis. Now, this is a prosthesis that is always in the form of a splinted prosthesis, either a bar with a removable overdenture or a fixed prosthesis. A screw-retained hybrid is the term that we use typically. Probably the biggest hang up here is the transition line location. Identifying that position, planning for it properly in the beginning stages of a case like this. The other aspect is anterior-posterior spread on your implants. We're going to hear that term a lot throughout our presentation today. AP spread is critical on these types of cases. And if we account for both of these factors, we can achieve very nice results.
The biggest problem I run into is usually not surgical stuff, it's not patient stuff, it's communication. And I think all of us will agree that's the biggest thing we run into, is the lack of communication between the restoring dentist and the implant surgeon. And when they don't talk, the lab gets stuck in the middle.
In our opinion, the ultimate way to do this, obviously, is fully guided implant surgery. Using software like Nobel Clinician, using Nobel guides, very restrictive surgical templates, really taking all of the guesswork out of the process and ending up with very predictable results in the end. That's the best way to do it, hands down. The ultimate, I think, is the fully CT-guided surgery. Again, the example that we are using today here is the Nobel Clinician software. It's predictable. It allows us to completely plan the surgery in advance. It's a far easier surgery, recovery, and restoration for the patient.
When four implants are splinted rigidly together at the coronal portion, that means something is rigidly holding them together. It's not removable. Implants angled up to 30 to 45 degrees have the same success rate as single implants. The whole concept is to be able to tilt implants to avoid things like the mental nerve or the sinus and still gain enough anterior posterior spread to be able to place a fixed hybrid on top of them. In summary, pretty much, dentures on implants are just a different animal than single implants. They're not planned the same way at all.
It just seems like we're trying to set new land speed records. Everybody's talking about how fast. Let's spend a little bit less time emphasizing how fast and how quick we can do this, and a little bit more time on how well we can do this. And what I want you to look at is the 2D. This is the anterior relationship, here's the posterior relationship, but you got this acrylic cantilevered lingually and buccally, and you can just see what's going on. Luckily, we had a lot of vertical height here, which makes a lot of things possible. But pay attention to the cross section. So this is the full wrap bar. Then I went ahead and redesigned this same arch as a Montreal bar. We have to combine the best components that material science has to offer, combined with the best techniques, both clinically and technically, the most meticulous, most accurate techniques, and the digital technologies. Clinician in the front end and planning of the implant positioning, strategic planning of the implant placement, Procera design software to do these fabulous bars. If we combine all of that, it's amazing the level of quality, restorations that serve these patients so well, that they so deserve. It's amazing what we can do.
So once again, we've gone through the whole process, and we've got somebody who's really happy with the final result, and that's what counts. That's the way it should be. This is the type of result we should be able to deliver time and time again with the technology and the materials and the knowledge that we have available at this point.